All right, welcome back everyone. So we're going to pick up here and we're going to talk about blood pressure, and in particular we're going to talk about arterial blood pressure, and then we'll do our next part and we'll look at venous blood pressure, right? So blood pressure is simple, and you all know about blood pressure, at least in some sense, right? If you go to the doctor and you have your blood pressure taken, right? Somebody has high blood pressure, they have hypertension, so you've heard of this at least in passing, right? So simply, all blood pressure is it's the force of blood against our vessel walls, right? And so we're specifically going to be looking at first, we're going to look at arterial blood pressure, and then again, like I mentioned, we'll do venous blood pressure in just a little bit, right? So blood flow, just in general, which is going to contribute to the pressure. Blood flows following a gradient, right? So meaning it's going to move from areas of high pressure to low pressure. And what we'll see is that we get differences in different types of blood vessels, right? So meaning arteries, capillaries, veins, the size of the arteries, the size of the veins, things like that, right? So in general, pressure is going to be highest on the arterial end, so in arteries, and it's going to be lower in veins, right? And so you can think about this for a few reasons, right? One, and kind of the main reason, is that on the arterial end, on the arterial side of the circulation, we have the heart, right? So the left ventricle is pumping blood up and out of the heart. And so every time the blood every time the heart contracts and it ejects the blood, that blood is then being forced against the wall of the artery, right? So any vessel that's closer to the heart, it's going to have a higher pressure because it's going to be closer to that force of the left ventricle, right? So as you move further away from the heart, as you move further away from the left ventricle, so into the capillaries and veins, then the pressure is going to inherently drop, right? So again, we're going to look at arterial blood pressure. So the pressure and the flow is going to go through in different phases and different cycles in these pulses, as we'll see. And so you can feel your own pulse, right? If you feel your radial artery, we'll look at a few others. There's brachial, femoral, carotid. There's lots of different areas that you can take a pulse at, called pulse points. But these pulses correspond to the contraction of the heart and this pulsatile movement of blood through the vessels, right? So on our arterial end, whenever the heart contracts and it ejects the blood out of the heart, and that blood moves through the arteries and it puts pressure on the arterial wall, that's called the systolic blood pressure, right? So it's the pressure of blood against the arterial wall during systole, so while the ventricle is contracting, right? In a blood pressure, this is the top number, right? So if you think of a normal blood pressure, maybe 120/80, right? A kind of a classic textbook normal blood pressure. The 120 millimeters of mercury, the 120 is the systolic pressure, right? You also have the diastolic pressure. So diastolic refers to diastole, which means relaxation, right? So systole meant contraction, diastole means relaxation. So this is, again, it's the pressure of the blood against the arterial wall, but when the heart is relaxing. So when the ventricles are in the relaxed state, right? And so that's the bottom number on a blood pressure reading, right? So maybe that's the 80 in our normal 120/80, right? The 80 millimeters of mercury, that's the diastolic pressure, right? And so you can then take the systolic and you can take the diastolic and you can subtract them. So you can subtract the diastolic from systolic and you get something called pulse pressure, right? Pulse pressure. So simply you take the top number minus the bottom number, whatever that number is, that's your pulse pressure, right? What this is a reflection of the elasticity of our arteries, right? So to what extent can the vessels fill with blood? Blood is ejected into them. They can stretch, but then recoil back to their normal size, right? The normal diameter, right? And so we tend to see that this changes, that this pulse pressure will change as we age in response to the decreased elasticity of our vessels as we age. So development of atherosclerosis, things like that, plaque buildup, right, things like that, right. And again, as we mentioned, you can feel this pulse pressure. You can feel the pulsatile movement of blood in those different pulse points, and we'll look at some of those, right. So again, a pulse, it's just this blood flowing in the vessel, right, causing the kind of expansion of the vessel. So these different pulse points, they are typically somewhat superficial, right? So it can't be a super deep artery because you won't be able to feel a super deep artery, right? They're not close to the skin. So these are close to the skin. You can take your pulse from it, so you can figure out the heart rate, right? So you could count by, count for 10 seconds and multiply it times 6. You could count for 20 and multiply it by 3. You can count for a whole minute, things like that, right? And so this is important clinically in that diminished pulses, or the pulses not being as strong, can indicate poor circulation or poor perfusion to a particular body area, right? And so some common pulse points: radial artery, so on your thumb side, your carotid pulse, right? Femoral, one called your dorsalis pedis, which is on the top of your foot. You can get one called your posterior tibial pulse, which is on the back side of your medial malleolus, so kind of on the back side of your inner ankle, things like that, right? So here are a few examples of where you could feel those, right? So again, your carotid pulse, right? So here's your common carotid artery on your left side, where it then bifurcates into internal and external. You could get a radial, right? There's brachial. So there's lots of different areas that you can get a pulse at, right? So this image here is showing the kind of a visual representation of your systolic and diastolic pressures, right? So again, just like we mentioned, again, a normal 120/80. 120 systolic pressure against the vessel wall during contraction, right? So notice the stretch of that vessel. And then you have the diastolic pressure, still the pressure of the blood vessel against the wall, but during diastole, during the relaxation. So that's obviously going to be a smaller number because it's when the ventricle is relaxed, right? When it's not exerting that force against the vessel wall, right? And so this is showing the differences in systolic and diastolic pressure across different types of blood vessels, right? So blood pressure compared to, or in different vessel types. So aorta, arteries, arterioles, capillaries, venules, veins, and then your vena cava. And notice that just in general, your blood pressure, both systolic and diastolic, are going to decrease as you move from the arterial end toward capillaries toward the venous end, right? And you'll also notice that there's a smaller change, or a smaller, not a smaller change, but a smaller difference in the systolic versus diastolic as you get further away from the heart, right? So as you move into arterioles, capillaries, and venules, that pulse pressure is getting a little bit smaller, right? So we're changing the difference in that, right? Now, there's another term, and you can see it on the image here, this MAP, this MAP, right? So MAP stands for mean arterial pressure, and this is a more kind of high-level overview of blood pressure across the cardiac cycle, right? And so what you do is you have to do a little bit of basic math, okay? So you're taking your diastolic pressure, okay, and then you're going to add your pulse pressure divided by 3, or you could do pulse pressure times 1/3, whatever you want to do, right? So again, you have to figure out pulse pressure, right? Remember, pulse pressure is your systolic minus diastolic. Divide that by 3, and then add your diastolic pressure, right? So you could do 120/80. So take your diastolic pressure, which is 80. Take your pulse pressure, okay, which is 40. So 120 minus 80 is 40. Do 40 divided by 3 plus 80, right? And you'll get something around 93, right? Somewhere around there, right? So what you're looking for is you're looking for a MAP, a mean arterial pressure, of somewhere around 60 or higher, right? In different clinical units, different hospital units, they may have their own kind of threshold. They may have standing orders to treat blood pressure or treat a patient with a MAP less than 65 or less than 60 or something like that, right? But sometimes it is more relevant. It's more important, if you will, than just an individual's overall blood pressure, right? So looking at MAP, okay? You can then look at your blood pressure all the way down at the capillary level. So again, before we get to the venous end, right? And at this point, the pressure is fluctuating little, if any, between the phases of the cardiac cycle, right? So between the systolic and diastolic phases of the cardiac cycle, right? And as we talked about in the previous part, the main pressures that are important at the level of the capillary are your hydrostatic and your osmotic, right? So again, you need a sufficiently high net filtration pressure on the arterial end to promote filtration, and then you'll have a much smaller pressure on the venous end that promotes reabsorption, right? So again, filtration on the arterial side or arterial end of the capillary, and then you'll have reabsorption on the venous end, right? If you have a significantly high pressure, which would result in a significantly high MAP or mean arterial pressure, you can end up with something called cerebral edema, right? So cerebral edema is essentially the accumulation of fluid in the interstitial space in the brain, right? And so if you think about our capillary filtration process, right, the net filtration pressure is it's essentially a function of your blood pressure, right? So if you have a really high blood pressure, really high MAP, you're going to end up having a really high filtration pressure that's going to force excess fluid out of the capillaries, and maybe not all of that fluid is going to get reabsorbed back on the venous end, and it's going to accumulate in the cerebral tissue, right? So you'll end up with this brain swelling cerebral edema, right? And we'll just go ahead and look at venous blood pressure instead of stopping and doing a separate part. So we'll do venous blood pressure here really quickly, right? So for the main thing to consider when you're talking about blood pressure on the venous end is simply how are you getting blood back to the heart? Because as you see here, venous pressure is low and it's not pulsatile, right? So remember, the venous end is furthest away from the left ventricle, and so it's going to be relatively low, right? So you've got to have some type of mechanism to promote blood moving back to the heart, right? So one is called the skeletal pump, and one is called the muscular pump, right? So you can read here a little bit about the muscle pump. I'm going to show you a graphic here. So simply what you have is veins in the body that course and run next to skeletal muscles. As the muscles contract, they're forcing and they're pushing on the blood vessel, creating a kind of regional area of high pressure. And then there's a more distal area an area further away that's lower pressure, right? And as we said earlier, blood's moving from high pressure to low pressure, right? So this is, the reason you've been told, if you've ever been standing still, you're on a plane, or you're standing upright for a long time, don't lock your legs. Every so often, contract your quads, your hamstrings, your calves. What you're doing is when you contract those muscles, you're squeezing on the blood vessel, and you're promoting blood flow back to the heart, right? And again, remember, you have the valves here as well, right? So the valves are assisting in the return of blood too, right? You also have one called the respiratory pump. Okay, so again, you can read here. I'm going to show you an image of what is essentially happening with our respiratory pump, right? So with respiratory pump, it's dependent on pressures in two areas, right? Pressures in the thoracic cavity and pressures in the abdominal cavity or abdominopelvic cavity, right? So as we breathe, right, our diaphragm changes shape. So the diaphragm is this long, kind of broad muscle that separates our thoracic cavity that you see in green and our abdominal cavity that you see in kind of the pink-purple color, right? So as we inhale, the diaphragm flattens. Okay, so it goes from this kind of dome shape that you see on the right here to this much more flat shape, right? Well, as you contract the diaphragm and it flattens, it puts pressure, or it decreases the size of the abdominal cavity, which increases the pressure, right? So again, we know that blood is moving from high pressure to low pressure. So blood is moving from high pressure in the abdominal cavity because the flattening of the diaphragm is increasing the pressure on those veins, to low pressure in the thoracic cavity, right? So notice here that you have increased intra-abdominal pressure and you have decreased intrathoracic pressure. All that means is that the blood vessels in the abdomen are under higher pressure than the blood vessels in the thoracic cavity. So blood does what it does. It moves from high pressure to low pressure up through the vena cava toward the thoracic cavity and to the heart, right? When you relax the diaphragm, so in other words, whenever you exhale, right, so expiration here on the right, the diaphragm goes back to being that dome shape, right? That increases the size of the abdominal cavity, decreases the pressure on the veins, so think vena cava, iliac arteries, things like that, or iliac veins, excuse me. And so as you decrease the pressure, blood flows back into them, again, high to low pressure, until you inhale the next time. And then you put pressure on them, blood moves up toward the thoracic cavity and the heart, right? So both types, whether you're talking about the skeletal muscle pump, if you're talking about the respiratory pump, both are dependent on changes in pressure, right? You have to have changes in pressure, right? So a general rule to think about between pressure and volume is that as you change the volume of a space, the pressure is going to change in the opposite direction. So as you decrease the size of a space, of a volume here, you increase the pressure. As you increase the volume or size, you decrease the pressure, right? So that's just a little kind of helpful rule to remember, right? Now, for our veins, again, because blood flow is not as strong as what you have in the arterial side, you're at risk for potentially developing clots, right? So the technical term for a clot is simply a thrombus, right? So a common spot for these are in the lower, more gravity-dependent area, so think lower leg, calf, things like that. And there you call it a DVT, a deep vein thrombosis, right? So immobility, not moving, standing still, you're on a flight and you're not moving your legs, you're sitting still for a long time. These are all potential things that could result in the formation of a DVT, right? So it's not always just the DVT that's the issue. It's the fact that DVT could then mobilize, okay? That clot could move, and when a thrombus or a clot moves, now it's called an embolus, right? So you have an embolism. So an embolism is just a clot that has now moved. And the major concern here is that it could either go to the heart, cause a heart attack, it could go to the brain and cause a stroke, or it can go to the lungs and cause something called a pulmonary embolism, right? So the clot breaks free, lodges in a pulmonary artery, reduces blood flow through the pulmonary artery to the lung, and results in respiratory failure and death, right? So there's lots of things that are occurring in a clinical setting and outside of a clinical setting that are trying to reduce the likelihood that deep vein thromboses occur, right? So just as a brief example, in clinical settings, oftentimes patients are given blood thinners, so they may be given a medication called Lovenox, or sometimes it's called enoxaparin, and this is a blood thinner that is given to most patients who enter the hospital, maybe stay overnight, in an attempt to help reduce the likelihood that they form a DVT and then potentially have a PE, a pulmonary embolism, heart attack, stroke, things like that, right? You can also have varicose veins, right? Not as dangerous as what you have with a DVT and a potential pulmonary embolism, but this has to do with poorly functioning valves that result in blood moving the wrong way and causing kind of the engorgement and the dilation of small superficial veins. Sometimes you can find these on the back of the leg, knee area, like things like that. You can also have them in the rectal region, and here you call them hemorrhoids, and this is due to increased abdominal pressure. It can also be due to liver issues as well, can sometimes result in hemorrhoids. And so again, for blood pressure, this is kind of a summary slide to consider, right? So again, mean arterial pressure, blood pressure, what's promoting the flow of blood, the gradient, right, caused by the cardiac output, high pressure to low pressure, and then this last one, circulatory shock. This is essentially just poor blood flow to tissues because of hemorrhage, because of some type of allergic reaction that results in poor perfusion, obstructed vein, venous pooling. There's lots of different things that could result in circulatory shock. But with this one, your main goal here, from a treatment perspective, is to restore perfusion to the tissues. Right? You're trying to promote blood flow back to your peripheral tissues. All right. So we will stop here, and we'll begin a kind of a separate set of discussions, continuing to look at some kind of different aspects of circulatory physiology.